The concept of our study is based on the following. First, it is well accepted that statin therapy reduces the risk of mortality in high-risk patients. There's also recent evidence supporting that statin therapy increases the risk of diabetes and the worsening of diabetes, defined as the initiation of insulin therapy. Second, it is also well accepted that excess body weight contributes to the development and progression of diabetes, while increased physical activity and cardiorespiratory fitness in general mitigate the development of diabetes. I'm Professor Peter Kokinos. My affiliations include the Veterans Affairs Medical Center, Rutgers University, and George Washington University. I'm here to present the findings of our recent study published by Mayo Clinic Proceedings in the February 2024 issue. The title of our presentation is Progression to Insulin Therapy in Patients with Type 2 Diabetes according to Cardiorespiratory Fitness, Body Mass Index, and Statin Therapy. We thank the Mayo Clinic Proceedings for the opportunity to present our findings. Our cohort consisted of 187,352 U.S. veterans diagnosed with diabetes and not treated with insulin. Of these patients, 158,578 were treated with statins and 28,774 were not. All completed an exercise treadmill test with no evidence of overt ischemic disease. Based on the peak metabolic equivalence achieved in this test, we established 5 age and gender specific cardiorespiratory fitness categories, from the least fit to the highly fit. We also established 4 BMI categories from normal weight, that is BMI less than 25 kilograms per meter squared, to obese, that is equal to greater than 35 kilograms per meter squared. During the median follow-up period of 9 years, comprising over 1,800,000 person years, 51,182 patients progressed to insulin therapy. The adjusted rate of progression to insulin was 27% higher in those treated with statins versus those not treated with statins. This finding suggests that statin therapy worsens diabetes. We also examined the rate of progression to insulin according to BMI and CRF. The adjusted rate of progression to insulin increased gradually with increasing BMI levels. Conversely, the rate declined gradually with increased CRF levels. To evaluate the interaction between BMI and statin therapy, we assessed the rate of progression to insulin within each BMI category for those treated and not treated with statins. In this analysis, we noted a gradual increase in the rate of progression to insulin therapy with increased BMI for the statin and non-statin treated groups. For those with BMI less than 25 kilograms per meter squared, that is the normal weight individuals treated with statins, the rate was 23% higher compared to those not treated with statins within the same BMI category. The rate then increased gradually to 40% for the overweight individuals, 59% for the obese individuals class 1, and 90% for obese individuals class 2. The pattern was similar for those not treated with statins. However, the progression was substantially less pronounced. These findings support an independent and synergistic effect of statin therapy and BMI on type 2 diabetes progression. Next, we assess the impact of the interaction between cardiorespiratory fitness and statin therapy on the progression to insulin therapy. For the least fit patients treated with statins, the rate of progression to insulin was 43% higher compared to those not treated with statins. The rate then declined progressively with increased fitness and was no longer significant in the moderately fit patients and 11 and 30% lower for fit and highly fit patients, respectively. For those not treated with statins, the progression rate to insulin declined significantly across all cardiorespiratory fitness categories. The decline was more pronounced than the statin-treated group and was 45% lower for those in the highest fitness category. These findings suggest that the diabetogenic impact of statins is evident only in patients with relatively low cardiorespiratory fitness, specifically the least fit and low fit, and it is attenuated substantially by increased fitness. Finally, to examine if cardiorespiratory fitness mitigates the deleterious effects of both statin therapy and BMI, we examined the BMI statin interaction and the progression to insulin according to fitness categories. In this analysis, we noted that the increased rate of progression to insulin across the BMI categories was significant only in the least fit individuals. That is, patients with an exercise capacity of 4.3 METs. The risk increased progressively to 25%, 36%, 43%, and 52% for the normal weight, overweight, obese, and very obese individuals, respectively. For individuals in the next fitness category, exercise capacity of 6.6 METs, the rate was only significantly higher for those, and only by 14 to 15% in the obese and very obese individuals. The rate then declined gradually across BMI categories with increased CRF, that is exercise capacity, and was significantly lower even for obese, fit, and highly fit individuals. So what is the take-home message of our findings? Well, our findings suggest the following. First, statin therapy increased the rate of progression to insulin therapy. Second, the statin-related increase to insulin therapy was amplified by high BMI levels, especially when combined with relatively low fitness levels. Third, this amplification was attenuated by modest improvements in exercise capacity of approximately 6.6 to 8.8 METs, regardless of BMI status. Fourth, the modulatory effects of improved cardiorespiratory fitness on the rate of progression to insulin, regardless of BMI, strongly suggest that improving CRF may be more efficacious in the management of diabetes than lowering body weight. Thus, encouraging regular exercise for diabetic patients should become part of mainstream clinical practice to enhance cardiorespiratory fitness and lessen the rate of progression to insulin therapy. We strongly recommend that clinicians assess the fitness status of their patients by a standardized exercise test prior to initiation of an exercise program and advise their patients accordingly. We also recommend that all exercise is of moderate intensity and initially low duration. We recommend that the duration increases gradually by adding 1 to 3 minutes per session per week to achieve the recommended guidelines of 150 minutes or more per week. I want to emphasize that our findings represent associations and not causation. The retrospective nature of the study does not allow us to conclude causation regardless of the strength of the association. Thank you for your attention. I recommend that you read the article for more details.
We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.